Anemia is a blood disorder, and what occurs with anemia, some people may have heard of anemia before. It's pretty relatively common blood disorder. It's when you either have a decreased level of hemoglobin or red blood cell volume. So we had talked about how red blood cells are responsible for carrying oxygen throughout the body, and anemia is a situation where the levels of your red blood cells have been diminished. The primary risk factors associated with anemia are malnutrition and chronic disease. Malnutrition referencing decreased intake of iron, causing a major issue with that, and other chronic diseases will contribute to that as well. Some other things that will also impact anemia are prolonged use of analgesics, particularly non-steroidal anti-inflammatory medications can impair red blood cell formation, increased physical training, which can damage red blood cells, family history of anemia, heavy menstruation in females are all different things that can factor into the development of anemia. There is something called dilutional or sports anemia. So what this is, it's very common among highly fit individuals. What happens is, through exercise and being active, the blood plasma, or the liquid portion of blood, gets increased, but it doesn't affect red blood cell production. So what ends up happening is that the red blood cell count looks low in relation to the blood volume. So it's not so much that the red blood cells have decreased, but their concentration has gone down because of the increase in blood plasma. So the overall number is normal, and the oxygen number is normal, or the oxygen being taken throughout the body is normal. So sports anemia does not affect the person physically. It's just something that could possibly show up on a blood test. Sickle cell disease and sickle cell trait, two different conditions, both of which involve the formation of abnormally shaped red blood cells. So in this situation, the red blood cells don't have the normal round shape, if you will, that they normally have, but they kind of take on a little bit of a sickle cell shape. What happens with this is someone will have sickle cell disease if they have two genes for sickle cell. So it's a congenital disorder. It's a recessive trait, meaning that an individual would have to get the sickle cell gene from each parent. If they only have one, then they can possibly have what's called sickle cell trait. So in sickle cell trait, the person doesn't have the sickling going on all the time. It'll only happen in situations where maybe extreme exertion would take place, or dehydration. Whereas the person who has full-blown sickle cell disease has sickling going on all the time. It is a condition more common in the African American population, and one of the major risk factors associated with this condition is what's called exertional rhabdomyolysis. And what happens here is, in rhabdomyolysis, is it's a catabolic destruction of muscle tissue. So catabolic means breaking down. So what happens is an individual will actually have a breakdown in muscle tissue, and the myoglobin component, which is a protein cell in individuals with this, starts to circulate throughout the body, and it could cause one of the main concerns is that because of the overload of this protein, this muscle protein that circulates throughout the body, it obviously has to go through the kidneys, and the kidneys become overwhelmed, and the individual can experience kidney failure. So it's important to note in individuals, and this is commonly seen. This is a main risk factor for sickle cell trait. So if an athlete has sickle cell trait, it's important to note that if they suffer from dehydration while playing a sport, that this could possibly be a risk for them. So that's something to bear in mind. An individual with sickle cell disease, where they have both, they are much more prone to problems, even aside from just physical activity. Hemophilia is a blood disorder that impairs clotting ability. So this is going to affect the platelets, which are responsible for the clotting mechanism. There are various types of hemophilia. I'm not making you responsible for knowing all of the individual types of hemophilia. You should be able to recognize that they are forms, but I'm not going to make you recognize all the different types and all of the different clotting factors that aren't present in those individuals. Obviously, this becomes an important factor if you do have an athlete playing a sport and they have a form of hemophilia. It's certainly going to impact what happens with them from an injury perspective, because obviously any injury that involves bleeding, depending on what type of hemophilia they have, their care is going to differ, obviously, versus somebody who does not have hemophilia. There are some milder forms, where someone may get hurt and it just may involve, for instance, if they sprain a ligament, it may just cause some prolonged swelling. Whereas in some instances, injuries like that, could require them to have to get immediate transport to a hospital. So again, if you have an athlete with a version of hemophilia, it's important to know what type they have and really be aware of what their emergency procedures are for treating their condition. Both trauma and occlusion syndromes occur within the cardiovascular system. Anytime there's repeated blunt trauma, you could end up getting a distal ischemia. It's very common to see this on the hand and fingers, for instance, in catching a ball. Your book gives that as an example. So that could certainly occur with that. As far as vascular occlusions go, you look at the major sites of occlusion being coming from the major arteries in the body, the subclavian, the axillary, the popliteal, and the femoral arteries. So when you look at those being the common sites, the major symptoms of arterial occlusion, the 5 Ps, pain, pallor, paresthesia, pulselessness, paresthesia, and paralysis, are what are going to be the common signs that you see with vascular occlusion. So pain, obviously from the lack of circulation. Pallor is the pale color of the skin. Paresthesia is the numbness and tingling. Pulselessness is the lack of pulse from the lack of circulation to the air, and paralysis from the decrease in function. So those are the 5 Ps of vascular occlusion. Thoracic outlet syndrome is a specific type of occlusion injury. Most commonly, the subclavian or the axillary artery gets entrapped in and around the neck and shoulder girdle region. Usually where you see this many times is in repetitive work, postural issues. So you see this a lot in athletes that do a lot of overhead activity is a common area where you would see this. Some other occlusion problems that are associated with this, compartment syndrome is another occlusion problem that could occur as well. You commonly get this in the lower legs, in the lower compartments, more particularly in the anterior compartment of the lower leg. You tend to get this a lot. And something called Breuer's disease, which is a condition associated with tobacco use. So what happens with this is people who, for instance, smoke, they get inflammation in their arterioles, and they end up getting in both the upper and lower extremities they start to get occlusion symptoms because of the inflammation in the cardiovascular system. Deep vein thrombosis and pulmonary embolism. So a deep vein thrombosis is essentially a clot that forms What predisposes individuals to deep vein thrombosis is prolonged immobilization, surgery, or if they are in some form of hypercoagulable state. For instance, a lot of times when individuals have a surgery, particularly one to the lower extremity, but even one if they're on just bed rest period, they always do something to try to maintain circulation if, for instance, they can't move the lower extremity, for fear that they could end up getting a thrombosis. If you look, you see what's called Virchow's triad down there. So hypercoagulability, blood vessel injury, and stasis, or slowing of blood flow. The highest deep vein thrombosis risk occurs when you have all three of them. Okay, so that's your Virchow's triad, which really predisposes you to that. In the instance of a deep vein thrombosis, what you basically get is you get the clot formation, which inside the body that's known as a thrombus, and then the venous swelling occurs, and that's where the term thrombophlebitis comes from, because a phlebitis is an inflammation of the vein. Now, if for some reason that thrombus travels, okay, so anytime a clot is traveling throughout the body, then it is known as an embolus. And a pulmonary embolism is when that embolus travels to the lung. So the blood clot actually lodges itself in the lung and can actually block a blood vessel to a portion of the lung, okay, and cause part of the lung to die. So that's where both of these, so the two separate conditions, but they can be related to one another if in the instance that the thrombus does travel throughout the body through the circulation into the lungs. An aneurysm is a weakness in the wall of the blood vessel, and obviously anytime you have a weakness in the wall of the blood vessel, you're susceptible to that blood vessel rupturing. So basically what will happen is the weakness will form, there'll be kind of like an outpouching or a ballooning of the blood vessel, and then that will cause the blood vessel to burst. A false aneurysm is something that happens due to scar tissue formation. Your textbook on figure 616 actually has a really good picture illustrating what a true aneurysm looks like versus a false aneurysm. A false aneurysm, there may have just been some trauma in and around an artery where some scar tissue was formed, and it doesn't change the diameter of the blood vessel. So aside maybe from some pain or something from the scar tissue that forms and maybe compresses nearby structures, there's nothing else really dangerous per se about a false aneurysm. You normally do not have a major issue. If the false aneurysm is a major issue, they can go in and surgically remove it. Where the more serious issue being the true aneurysm, where obviously if that was ever discovered, they would potentially do surgery to correct that as well. But again, the fear there being is that the actual blood vessel will rupture. And next we'll look at different types of headaches. Headaches are typically some sort of neurovascular problem. We look at migraine headaches and cluster headaches, two headaches that can cause a great deal of pain. With your migraine headaches, you have some of your proposed causes listed. They could either be serotonin issues, inflammatory effects on the trigeminal nerve, various other hormones can produce that as well. Cluster headaches, you look at psycho-emotional stress, alcohol, tobacco, and again, other nervous system issues as well. Part of what you will see as far as the difference is specifically between migraine and cluster headaches is the symptoms that the person has, where their pain is, coupled with some of the other symptoms. Your toxic vascular headaches, these are kind of the general, very diffuse types of headaches that a lot of people get for various reasons, be it infection, alcohol or caffeine abuse or withdrawal, hypoxia, hypoglycemia, various metabolic disorders. Usually for the most part, the treatment is going to vary depending upon what the actual cause of the toxic vascular headache is. And then just looking at some pediatric issues in general, most of the time pediatric chest pain is not related to the cardiovascular system. Many times it is more of a musculoskeletal issue, particularly getting referred from the thoracic spine. So a lot of young children with thoracic spine issues will complain of chest pain, kind of, in the front or the lateral portion of the chest wall. So typically a lot of times it's more of a musculoskeletal issue. It's usually not due to cardiac pathology. It is important to be aware of a family history of heart disease. So it's just important to note, again, that's why, again, obviously, looking at medical history forms and things of that nature will kind of clue you in on that. But many times you're not looking at a straight cardiovascular issue as far as chest pain is concerned. One thing to do note are different types of congenital heart conditions, so septal wall defects, so any type of defect in the wall of the heart, or the vascular anomalies, some of which we talked about. It's important to know that many of them don't interfere with participation. They may have some symptoms, but again, it's important to just be aware of, if you do have an athlete with a pre-existing condition, kind of know what it is, know how they're getting treated for it, know how they're following up with their physician for it, and just kind of be prepared that you may deal with issues with that if they were cleared to play. Again, just being aware of the conditions is probably the most important part of it. And this is an outline of your learning outcomes. So just kind of an overview of what we went over, what you need to know as far as the cardiovascular system is concerned.